Hello, everybody. Welcome to this week's Independence Age briefing. So, since the start of the COVID-19 pandemic in early 2020, life's been very challenging for many, but it's even more so, and especially so for people who are vulnerable and at high risk of being infected, because they're immunocompromised, because they're particularly in an older age group. And many of us have kind of returned to somewhat normal lives and some version of living with COVID, but people who are immunocompromised and people who are vulnerable have really continued to suffer because they don't have that option of just deciding to live with COVID. Today, what we're going to do is think about what we're doing to support them. What are their needs? And what has their experience been like in the last 2 years? How can we make things better for them going forward? And particularly, what treatments are at their disposal so they can live a comparatively more normal life? We want to talk about antivirals and how far they can go and how well they work. And this is what we want to continue in this whole session. And we're going to have some experts who will guide us through all of that. But first, we're going to do what we always do, which is look at the numbers. And Duncan Robertson is going to tell us what's going on with COVID this week. Over to you, Duncan.
Thank you very much, Helen. So we're very much in this BA4 and BA5 wave. And I think what we're going to talk about today is how that's affecting the populations. So let's see if we can present this. So we're finding that the number of people who are testing positive on the ONS survey is increasing in all of the UK nations, and particularly ahead, if you like, is Scotland, which has a higher number of people testing or high proportion of people testing positive. And we're starting to see, as well as a number of people testing positive, we're starting to see hospital admissions increasing. And of course, they're delayed. But we are seeing a very clear signal of that at the moment. And as well as the number of people actually going into hospital, we're actually seeing the number of people who are in hospital increasing too. And fortunately, this hasn't really fed into the data for the number of people who are, the most sick in mechanical ventilation beds and deaths. So, but of course, they tend to follow later. So in terms of people testing positive, this is from the ONS survey. And there we can see split down into the 4 nations of the UK. Scotland there with relatively high numbers of people testing positive. But of course, Scotland has slightly higher uncertainty. But I think we can see that all those regions or all those nations are increasing. So this is the BA4 and BA5 wave that we're in at the moment. So if you split it down into the last 4 weeks, we can see that each of those nations is kind of steadily going up, with Scotland, as I say, ahead in terms of the percentage of people testing positive. And this applies to regions of the UK. All England regions are increasing, perhaps with the exception of the southeast, which may be staying still or increasing. So this is spread across the nations and across the regions, and also across ages as well. So we can see levels increasing in all age groups. This is for England, with highest amongst the kind of working age populations and older school children. And this is a chart that's, I think, been shown before, but it's really kind of looking at the history of these waves and how the number of people testing positive changes. So that kind of blue dashed line, the heavy blue dashed line there with the scale on the right-hand side, is showing the number of people or the percentage of people testing positive. And as you can see, it tends to follow these waves that we get. So we had Delta in October, BA1 or the original Omicron in the beginning of January. We've had the BA2 wave, which we're kind of getting over, but now we're going into this BA4 and BA5 wave. So as you can see, these waves of the variants tend to have waves of infections. This is from the ONS infection survey, and as you can see, there's between say 2 and 3% in England, but higher rates in Northern Ireland and Scotland. So you can see actually Scotland does kind of seem to be ahead in terms of the number of people testing positive up to relatively high levels. In terms of hospital data, we've got 2 types of hospital data. We've got the number of people who are being admitted to hospital. And as you can see, we're starting to get this wave in terms of people being admitted, doubling, say, every 2 weeks. Now, we don't know what's going to happen in the future, but we're certainly at the stage where we are at this increasing stage of admissions to hospital, which obviously puts pressure on the hospital system. And this is split down into over 65s, who are at the that upper line, and the under 65s. And these are 7-day moving averages just to smooth them out. So both of those are increasing. This is looking at the rates per 100,000. Instead of looking at the kind of absolute number, you can look at the rates. And as you can see, over 65s, the rate of people is increasing, particularly in those age groups. And this is splitting it down further, as well as the over 65s. We can see rises in 65 to 84-year-olds and lower absolute increases in working age population. And it's consistent across different regions of England. We can see that admissions are going up in all England regions. So it's not just confined to one part of England. And this is for under 65s also increasing as well. So you can see it's kind of consistent rise in infections and a consistent rise in number of people being admitted across England. And I think, the other way of looking at hospital data is to look at the number of people who are actually in hospital. So what we have seen coming out is that this has been going down, but now we're at the stage where actually the pressure on the health system in terms of beds that are occupied is increasing. Now, of course, these aren't always, so if you test positive for COVID, it doesn't mean you're being primarily treated for COVID. So this is how you split out those. And as we can see that the number of people being treated for COVID is increasing. That's that bottom blue line. So it's only a proportional number of people who are being treated with COVID, but there are people in hospital who are being treated primarily for COVID, and that's increasing. And this is looking at the number of people split between being treated for COVID and being treated with COVID. And as we can see across the regions, that's also increasing. So we're getting a kind of a strong signal that this is affecting the health system. One, I suppose you take what you can in terms of the number of people who are in mechanically ventilated beds. This is increasing. It's at a relatively low level, but I think we're seeing that the number of people in mechanically ventilated beds is increasing as well. And just this is putting the whole pandemic into perspective. So this is from the beginning of April 2020, right at the beginning of reliable data up until now. So you can see the kind of history across to kind of put those peaks into perspective. So we are at this stage of the BA4 and BA5 wave increasing, but relative to the kind of January 2021 peaks, it's relatively low, but it is increasing. And the trouble with these things is they tend to double, so you can get relatively high relatively quickly. And this is the same chart, but for mechanical ventilation beds. So this is where it's starting to increase, but relative to the kind of January 21 peaks, it's relatively low but increasing. The other thing about variants, just to say we are in this BA4 and BA5 wave. So these charts on the right, these the red and the kind of pink are the proportion of variants. This is June the 11th data, but it is over 50% in terms of the number who are the proportion of this BA4 and BA5 wave. This is where they are in the country. So BA4 on the left and BA5 on the right. And this is from Sanger data, so it's only a part of the data that we have. And once again, similar way of looking at it, we can see this BA4 and BA5 wave, the red line, increasing as we get as that replaces infections with BA2. So this is all Omicron, but it's going from BA1 to BA2 to BA4 and 5. And finally, deaths. We are at a relatively low level, but all these deaths are very sad. But we haven't quite seen that increase yet. If you look at the data in terms of number of deaths reported, that has increased in the latest release, but that's could be down to the Jubilee effects. So this is by the date of death. So we haven't seen the signal kind of into deaths yet, which is good. And finally, vaccinations. This is what people individually can do. Vaccinations. We still have a significant proportion who are unvaccinated. Say roughly 20 to 25% of the population. And we do have very low levels of vaccinations at the moment. So, I think looking at the most vulnerable people and children as well, the opportunity is still there, of course, to get that vaccination and to become as protected as you can. This is for the over 75-year-old boosters, and it's been relatively successful, but there are still some over 75s eligible for those boosters who haven't come forward. And looking at 5 to 11s, these are the most recent group to be able to be eligible for vaccines. Still low levels, particularly in England and Northern Ireland. So there is still time to get vaccinated, particularly for these children who will be going back to school after the long summer holidays. And this is the chart from UKHSA showing, in the bottom right here, 5 to under 12s. This is for their first dose, really very low numbers. This is for England compared to the other age groups. So there's still some work to go there. And this is looking at 12 to 15s and 16 to 70-year-olds across the various countries or nations of the UK. So really, there we are. The headlines, as I say, we're in this BA4 and BA5 wave. The number of people testing, the proportion of people testing positive in this ONS representative survey has increased in all the UK nations, particularly in Scotland. Hospital admissions are increasing, doubling roughly every 2 weeks. And as well as that, you've got the number of people in hospital increasing, but we are still at relatively low levels of people in mechanical ventilation beds and sadly deaths. So there we are. I'll end that briefing.
Thank you very much, Duncan. That was really, really informative. We're now going to move on to our main session. And as I said earlier, we're going to be thinking about what life has been like and what it could be like for vulnerable people, for the clinically extremely vulnerable who are at increased risk of COVID in this pandemic. And we're going to also think about the role of antiviral medications in this. And I'm going to call on Dr. Stephen Griffin and Professor Sheena Cruickshank, who are going to host this session and introduce our guests.
Great, thanks so much, Helen, and hello, everybody. So as Helen's alluded to, we're really trying to focus now on the therapeutics that are available to treat either severe or COVID that's in more clinically vulnerable people, because Duncan's briefing has been fantastic in showing us what's been going on, but many people around the country, as we're being told by the Living with COVID strategy, may look at those prevalence numbers and say, well, so what? Are we seeing as many people in hospital? No. Are we seeing as many people dying? No. But the fact is that whilst our vaccines are incredibly important at reducing that level of severe infection, alongside those vaccines, we almost have sort of the mainstay of our Living with COVID strategy from the government that basically says that it's okay for clinically vulnerable people because they have access to these therapeutics. And there are two types of therapeutics, these monoclonal antibody therapies and new and newly available direct acting compounds that act against the virus itself. Now, this again leads many people to sort of say, well, we're okay, we can move forward. But actually, if we look at this in a bit more detail, we need to ask questions like, are these therapies really doing the job? Are people able to access these therapies properly? And do they benefit the people that are in line to receive them in the way that we hope that they would, and protect them against severe disease? So we're going to be talking about these two types of therapies today with two amazing experts who I'm very, very pleased to welcome to our briefing. The first, and it's important to say that these guys are both incredibly brilliant world-leading researchers, but also clinicians at the leading edge of treating people with these diseases. So they really do know what they're talking about. And the first person we're going to welcome is Professor Alex Richter from the University of Birmingham. And as well, we have Professor Ravi Gupta from the University of Cambridge. And I'm going to hand over to Sheena now, who's going to talk to Alex about monoclonal antibody therapies. Over to you, Sheena.
Thanks, Steve. And I'm basically going to hand over straight to you, Alex, because I think we should start by trying to understand a little bit about what these things are.
Thanks, Sheena. I just thought it'd be really helpful to put some slides up just to talk through monoclonal antibodies and what are they. There's been a lot of discussion in the press about Eversheld in particular. And I thought it'd be good to go back to basics to understand what a monoclonal antibody is, how we've been using them, and what we're going to do with them. Is it possible to put the slides up? Oh, that's great. So just move straight on. So a monoclonal antibody. Let's talk about antibodies first. We've heard a lot about antibodies, and as a clinical immunologist, I'm utterly delighted that the whole population now knows about antibodies and T cells. So we've had a huge upskilling. We need antibodies to clear infections, and importantly, they protect against future infections so that they help us with our immune memory. Now, antibodies come in all different shapes and sizes, and we need lots and lots and lots. We need hundreds of thousands of different varieties of these to protect against this huge wave of pathogens that we're presented with every single day. And one of those targets at the moment is COVID-19 and the virus associated with that, SARS-CoV-2. So a monoclonal antibody, so monoclonal just means one clone or one type, is a single antibody that only works against one target. So what we can do, if we go to the next slide, is manufacture antibodies that only have one clone. So we can then give those as a treatment to patients at higher dose. So you could say, well, what about vaccines? Surely vaccines do the same, because if you give a vaccine either as the virus or part of the viral particle, you provoke an immune response, don't you? And we've heard about antibody levels post-vaccination and how that has broken the link between infections and hospitalizations and death, which has been fabulous, part of our strategy. Now, these take about 4 to 6 weeks to work because you're relying on the immune system to do their job. And we also have learned over the last few years that unlike some vaccines, like measles, which give us lifelong protection, these COVID vaccines are maybe only lasting about 6 months. And so we've had we've had a booster program, haven't we, over the last year. So in contrast to vaccines, we've got monoclonal antibodies. And rather than taking 4 to 6 weeks to form, basically as soon as that monoclonal antibody goes into a patient, it's working immediately. Those antibodies are preformed and they are ready to do their job. So it's directly administered, immediate onset. And because these are manufactured antibodies, you're able to change slightly how long they last for. So usually antibodies have to be renewed every 21, 28 days, whereas these antibodies can be in the system for at least a year. So that makes it possible to have a long-term strategy with these monoclonal antibodies. So I guess we go back to the question is why would we need monoclonal antibodies? Because we've got vaccines. Brilliant. Well, the patients that I look after in clinic, and I look after immune deficiency patients, either because they've got a genetic defect or because their immune system has been suppressed because of an underlying blood cancer or a treatment that they're on. My patients don't respond very well to vaccines. And there are lots of patients around the country, we think maybe up to 500,000, who haven't responded as well as someone with the healthy immune system to vaccination. So we've got a great national strategy for the majority of us who have healthy immune systems because these vaccines are doing so well. What about those that aren't doing so well? So if we go on to my final slide, I want to just show you how we've been using monoclonals to date in the UK. Now, we can use monoclonals to treat acute infection. So the first monoclonals that were used and licensed in the UK, one called Ronapreve, you'd be admitted to hospital, and then one of the early treatments you would be given if you were in one of the vulnerable groups was a high dose of these monoclonal antibodies. And what we learned through the recovery trial and other studies is that earlier you give those antibodies, the better the outcome. And that makes sense because, you know, antibodies work really quite early in the immune system, in the immune process. So what we then did is when we set up the COVID medicines delivery units and the antivirals came on board, patients that were vulnerable and likely didn't have good vaccine responses were given this different monoclonal called sotrovimab in the community. So they weren't admitted to hospital. They were diagnosed with COVID, and they, as an outpatient, would be treated with this monoclonal antibody therapy. Now, these monoclonals, as I've said, are against a very, very specific target, and this comes back to variants and how well these monoclonals are working against the different variants. Now, there was some feeling that Ronapreve wasn't working so well and sotrovimab wasn't so well. So the use of them has been diminishing. But the evidence for them not working so well is very mixed. And sometimes that can be overcome with dosing. And the understanding of whether it's better to have some monoclonal on board than not, those studies have not yet been done in those immune deficiency patients. Because the largest studies, the big recovery studies, have been done in all comers. But what we're starting to do is realize we've got a subgroup of patients who are going to continue to be vulnerable. So our strategy for learning how to look after them over the years ahead, we're going to have some of these studies to understand what is the best way of treating patients and where monoclonal therapies come into that pathway. Now, back to the last slide, if we think about another way of using monoclonal antibodies, I've said that they need to be used early. Now, in the immunology clinic, I use antibodies early, in fact, pre-exposure. So I use immunoglobulin product, which is antibodies collected from lots and lots of patients through plasma donations. And we give patients with antibody deficiency infusions every 3 or 4 weeks to top them up with general antibodies. So we use pre-exposure prophylaxis already in the NHS. We also use it early post-exposure for things like chickenpox in an immune-suppressed patient, rabies. So we've got various techniques that we could use. So the use of pre-exposure prophylaxis is well established in the NHS, and we know that it works at preventing infection in these immune-suppressed patients. So there's a newer monoclonal that was licensed in the UK, Eversheld, which has been licensed not just for acute infection, but for prevention of infection with pre-exposure prophylaxis. But this has not yet been available, and it's not yet in clinical pathways. And a really common question to me is, why not? Why can't we have access to this? So we need to understand how well these treatments work against Omicron, who's going to benefit most from them, and really try and get the evidence together so that the policymakers in the UK can hopefully offer this as a solution for living with COVID with immune deficiency going forward.
Thank you so much, Alex. That was really comprehensive and really clear kind of background and also scenario setting. And you know, you mentioned Evershield, and you know, there's a lot of different groups of patients that are probably eligible for these things, but could you sort of take us through the kind of approval process, or how do these drugs come into use, or how do they get tested so that patients can understand, you know, what the pipeline is for anything that like this?
So there are initial safety studies done with any drug. And I'm sure many of us now have heard about phase 1 trials, phase 2 trials, 3, 4. So all those trials are undertaken. And when they are successfully undertaken, those are reviewed by our medicine safety committees. And in the UK, that's the MHRA. And they, you know, they check that, one, the drug does what it says it's going to do, and they review all the literature provided. And 2, they check whether it's safe. So that's one set of decision making. We then have to think about adoption. And decision makers in the NHS or NHS England and government will then make a decision around cost effectiveness. I think it is, you know, we have to accept that we have a restricted healthcare economy. We can't afford everything in the NHS that we would like to do, Sheena. And so decisions are made on the clinical cost effectiveness of this. So questions like, how many people do we need to treat to prevent a hospital admission or prevent a death? So those decisions will be made by committees. I'm sure you've heard of the National Institute of Clinical Excellence, NICE. NICE is involved in a lot of this, but other bodies have been set up during COVID to bring expertise together more rapidly to try and get that into practice. So at the moment, Evershield has been licensed, so they've decided it does what it says on the tin and it is safe. But the decisions around whether they think it's going to be beneficial in the NHS is being made at the moment.
Thank you. I think that's really helpful to clarify for people. I'm going to move sort of on, because I think it flows really nicely into the next bit. I'm going to pass back to Steve to introduce our next guest.
Thanks, Sheena, and thanks, Alex. That was a really fantastic explanation of these therapies. So the flip side of these treatments for more vulnerable patients is more recent. We know slightly less about them, but one person that does know a lot about them is Professor Ravi Gupta from Cambridge. So Ravi's just going to take us through what the current use of these antivirals are, their long-term effectiveness, and which patients are getting them and able to access them in the NHS at the moment. Over to you, Ravi.
Thanks, Steve. So I'm very pleased to be here, and I was going to talk to you really about the other sort of class of treatments for COVID-19, and these are what we call small molecules or traditional drugs, as it were. So, of course, monoclonals are really interesting and cool, but they're very recent in terms of therapeutics. Most of the ways we treat bugs, such as bacteria and viruses, are actually small compounds that don't mimic, of course, in natural antibodies. They're actually often synthetically made, but they do mimic other things. They mimic other molecules that are found in our cells. So this goes back to the life cycle of a virus. So we are able to take advantage of certain things that viruses have to do in our cells when they make copies of themselves and cause infection. So one thing that a virus needs to do is to copy its genetic material, and that's done by something called a polymerase. And we've had drugs that block polymerases in viruses for a long time, going back to the HIV days and even before that. So we've learned over decades how to develop these drugs and design these drugs specifically against different types of viruses. And technology, computational biology has really helped us in this area. And we now therefore have drugs that target the polymerase of the coronavirus. The first one really was the one that we've used is remdesivir. And although this is a somewhat useful drug, it's not quite as potent or efficacious as we need these drugs to be. But of course, it was the first. There are derivatives of that coming along. In other words, modifications of that drug that may be more efficacious. So that's the polymerase. And of course, so if you stop the virus copying its genetic material, you can stop it from replicating. So that's one class. And of course, the more recent class of drugs is the protease inhibitors. And what the protease inhibitors do is block an enzyme or a function of the virus where it needs to basically chop up pieces of protein so that they can become fully functional. And the virus needs these proteins in order to, first of all, cause infection, get inside cells, and obviously generate more of its more virus particles. So again, proteases are very critical parts of the virus, and we're able to block that enzyme through use of protease inhibitors. And you may have heard of Paxlovid, which is a sort of the sort of commercial name, but the molecule is called nirmatrelvir. And this is very, very efficacious. So it reduces hospitalizations and deaths by about sort of 80%. So it's very, very good in the clinic. A lot of these trials were done, of course, with older variants, and they were done in populations that were not well vaccinated. So you have to look at those data from that perspective. Of course, it takes a long time to do good clinical trials, and things have obviously moved on by the time they're completed. But nonetheless, this drug does have very, very good therapeutic potential. It's a 5-day course, 1 pill once a day. It does have some drawbacks. In other words, one of the components can interact with some other medications that you may be taking, and therefore it needs to be prescribed by a doctor, and it needs to be prescribed with that in mind. So it's not a question of kind of going to the pharmacy and then just being given a pill. It does need a bit of regulation for safety reasons, and that may be one of the problems you see. Of course, as we go forward, as Steve said, we want drugs that people can maybe self-administer at home after a positive test, so that you give yourself the best chance of clearing the virus early on, without needing to see a sort of medical expert. But we're not quite there yet with these drugs, in that they do have complexities about them. But of course, we're moving very quickly towards having really good drugs that are easy to take and very effective. So that's good. The one thing I did want to, we may discuss this a bit later, of course, is that when we've used single drugs for other diseases such as influenza and HIV, we've very quickly run into problems of drug resistance because viruses evolve, and they evolve away from drugs just as they do away from antibodies. So one of the things we can discuss is the need for combination therapies. But I would, on the other flip side of that, say that in general, targeting these really important processes within viruses is generally a good way to go, because viruses tend to find it harder to mutate those proteins because they're very highly evolved. If you look at different related viruses in these sort of families, you find that the sort of sequence of amino acids and genetic code is very well maintained, because these proteins are optimized for their job. And if you start changing them, if the virus decides to change them, it may incur a cost to the speed at which the virus can replicate and cause infection and then transmit. So this is another reason why targeting these enzymes is a potentially good idea, because the ability of the virus to escape them is potentially diminished. Now, of course, in real life, with huge numbers of infections and high turnover of the virus in the body, lots of different mutations can arise. And so I think that despite that sort of good news about these targets. We do need to temper that with the fact that the virus will inevitably develop drug resistance to these drugs if we just leave them alone and use them in an unregulated way. Over to you, Steve.
Yeah, great. Thanks very much, Ravi. So going back to the sort of things that Alex was talking about, what determines whether a patient, usually a more clinically vulnerable or more likely to develop severe disease type patient, what determines whether they're given small molecule antivirals compared to the monoclonal antibody therapies, for example? And how important is it to give these therapies early? That's for you, Ravi.
I thought you said Alex. I'm sorry.
That's just you mentioned the clinically vulnerable.
I see.
Patients.
Right.
Yeah.
So, of course, when we had remdesivir alone in the early days, and then we had molnupiravir, which I didn't mention before, but is another sort of it's another inhibitor of the polymerase. In other words, copying activity of the genetic material. We were using those drugs in combination with steroids, for example, in people who needed oxygen, and during that period, I think monoclonals were still, if this is pre-Omicron, monoclonals still had good activity against the variants that we had, for example, Delta variant. So monoclonals were actually quite widely used, partly because, of course, our antiviral, the small molecules, were not as effective. We didn't have Paxlovid at that stage. And so when Paxlovid came along, was showing very high rates of success. It's changed the balance between use of monoclonal antibodies and these small molecules. And of course, Omicron has come along, which shows a degree of evasion of the monoclonal antibodies, whether it's Evishield or whether it's sotrovimab. And different flavors of Omicron have different sensitivities to both of those drugs. So actually having two different monoclonals available is fantastic. But of course, you need to know which virus you're dealing with in each patient. So one area we're lagging behind in somewhat is rapid diagnosis of what variant is infecting your patient in front of you. So the monoclonals have lost a bit of ground in a way because of Omicron and its escape, and because, of course, Paxlovid has come along. It's an oral tablet once a day. You take it for 5 days, and it's very efficacious. So you can see why the balance has shifted towards the oral drugs. But I would say, of course, there will be new variants, and the oral drugs may succumb to drug resistance in the future if we're unlucky, and if we don't act sensibly with those drugs. So hopefully that answers at least some of your question.
Yeah, sure, certainly. I mean, maybe I can let Alex come back to that in a second, but I was just wondering, from both of your perspectives, are the right people getting therapeutics now as compared to, say, for example, the list of people that were, for example, told to shield or were given 4 doses of vaccine? And sort of secondarily to that, and you mentioned about testing, Ravi, how is the reduction in testing and awareness affecting the provision of these therapies to people? Either Alex or Ravi, welcome to answer that.
We've been looking at the outcomes for our vulnerable patients with the recent Omicron waves compared to the Delta waves. And undoubtedly, things were a lot better. And I think the combination of vaccination, the combination of the antivirals, the monoclonals is all helping. Mm-hmm. But when we looked at that, we wanted to understand how many people had actually accessed the CMDUs, the COVID medicines units, and only a third had. Mm. So I wonder whether the message isn't out there that who is vulnerable or who is eligible for these treatments, and whether there is more we could do with accessing what treatment actually is available for patients.
That's a really important point. And there are several trials that are actually behind much of the antivirals provision in the UK at the moment. Ravi, could you explain a little bit about those and how patients could access those?
So yeah. So first of all, I think I'd like to echo that. I think that view, which is that clinically vulnerable individuals may not necessarily know who they are, because of course the list of conditions, including age, is rather large, and so it's quite clear that those who potentially should have been receiving treatment have not done so. There is obviously a generalized perception community-wide in the UK that of reduced risks from Omicron, and I think that's been, and of course coupled with the removal of many restrictions, it's tending to a sort of an atmosphere of optimism, which is a good thing in some ways, but of course it does diminish the importance of people getting tested and then seeking treatment, and of course when that treatment, these CMDUs are, the access to them is not obvious to patients, then of course that's why we have the situation we're in. What I really worry about is a new variant coming along that is more severe, and individuals don't know where to go for their treatment when they're infected with those new variants. So in the context of waning immunity as well. So that's why I think we need to get this right now, in anticipation of what may be coming later in the year. You talked about trials for new drug trials. I think that various centres in the UK are recruiting for new trials. I'm not sure whether Recovery has any novel antivirals in their arms at the moment. Maybe somebody else could chip in here, but certainly there are new antivirals being tested. There are monoclonals in the pipeline as well that are in trials. So I think that that inclusion in trials is something that should be done, and encouraged, especially in people who are vulnerable, because we really need to see, this is the group that we really want to see the benefits in, and if we can't recruit enough people with comorbidities or conditions that make them vulnerable, then we're not going to get the answers we need.
And actually, on the back of that, the monoclonal studies, there's going to be one for sotrovimab and for Evershed in clinically vulnerable patients. So just check with your local centre. Those should be opening over the summer.
That's great. And thanks both. I think maybe we might try it on Independence Age to try and get some more information, or at least the right links to those eligibilities and trials on our website as soon as we can going forward. So now thank you so much both. Really informative, but we also have a lot of interest from the public in this scenario. And so I'll hand back to Helen, who's going to chair the questions that we've been sent in. Thanks, guys.
Yes, don't go away, Ravi or Alex, we're going to need you. Okay. So our first question comes from Kaneman Giles. And I think we might have answered the first part, which is what, if any, work is going on to look at how people who cannot mount an effective immune response to vaccines will be protected from COVID. And I think you've really told us that already. But her second part is asking really why Evershed, which is currently the only drug approved in the UK for prophylactic use against COVID for people who are vulnerable, isn't being purchased, and what evidence is the government waiting for?
I can take that one, Ravi. So it goes back to that kind of cost effectiveness question, and working out how many people we need to treat to make this a cost-effective treatment. And the concern was from laboratory assays that these monoclonals weren't going to be as effective against the different Omicron variants. Now, it is one of the tools we have when evaluating a drug, is we can look in the laboratory to see, how effective they may be. But that's quite different to real life data. And it's very difficult to do a clinical trial where you're constantly variant chasing. I mean, every 3 months we have a new variant at the moment. It is simply not possible to do that trial to be completely up to date and provide the level of evidence that we would usually give for a drug in the UK. So it is that, that's why we've had to make a lot of pragmatic decisions in the UK, about extending the vaccine interval, for example. These were all pragmatic, not evidence-based decisions. But I think as we're moving, certainly politically out of the pandemic, even though cases aren't changing, that we're going back to previous decision-making on medicines to some extent. And I think there is a lot of reticence about the monoclonals in the decision makers because they think it may not be as effective against Omicron. And my view on it is it may be slightly less effective, but it's still offering something where there is nothing before. There is evidence and there are clinical trials, obviously from different variants. We are getting Omicron real life data out from the States at the moment. There's been a paper published. So it's just about trying to collate all this information, and hopefully, I think it's ultimately going to be a reasonably pragmatic decision. If we can identify these patients as remaining vulnerable and remaining at risk of hospitalization, and thereby preventing the NHS from getting back to whatever normal was, and thinking about winter pressures this winter, is this the best thing that we can do? And we might just need some pragmatic decision making about it. But it's a difficult situation, because I know patients feel incredibly vulnerable at the moment, and they want parity of antibodies with those of us that have responded well to vaccination.
Thank you very much, Alex. I'd like to go on to a question from Fraser now. Fraser, are you there? If you are, turn your camera on.
Yes, hello, can you hear me?
We can.
Okay, thank you very much. Hello to everybody today. My question is this: with the continual rise of the new COVID variants, for those that are vulnerable or clinically extremely vulnerable, truthfully, for how long are the top-up jabs going to keep folk protected, especially as our government has decided to dump public health measures and pretend that COVID was an inconvenient nuisance in the distant past? After all, only circa 4% of commuters on public transport bother to wear masks these days, putting everyone at risk from asymptomatic commuters and the creation of future mutations and variants.
Thank you very much, Fraser. Who would like to start with an answer to that question?
I mean, I could start by discussing the point at the beginning about using the same vaccine for new variants. Of course, we sort of the issue here is, of course, that we have a vaccine directed against the original virus that emerged, and now, of course, we have many different viruses. It was reassuring to see that 3 doses of vaccine could provide neutralization or efficacy against in the lab against Omicron, which was unexpected, because of course Omicron is vastly different from the strain used in the vaccine. However, coming back to Alex's point, if you get high enough levels of antibodies, you can sometimes overcome resistance. So that's great. But of course, now we have an issue about how often do you have to give the boosters to keep those levels up, and that's where we are a bit stuck. But there are some really promising things happening. There is the combination vaccines with the original strain plus the beta variant. Others are using the original strain plus Omicron, and so both Moderna and GSK have such vaccines. We call them bivalent vaccines or polyvalent vaccines. So things are moving, and these vaccines may allow us to extend the dosing interval between vaccination. In other words, you may be protected for a longer period of time against more variants by having by using these vaccines. So, and again, I've sort of talked about the first part of the question. I can't really comment on necessarily the policy implications, but at least protection of vulnerable people hopefully is going to get better.
I can also just chip in a little bit there and just say that vaccination is just one part of the strategy. And the treatments are the other part of the strategy. It is very difficult at the moment trying to advise people how to go back to work. And when I talk to my patients, I say, well, it's not black or white. You're not safe or unsafe. And actually, this is a sliding scale of risk. And it's about what we are prepared to do and how we, because actually not doing anything is also incredibly bad for us and incredibly bad for our mental health. So it's a sliding scale of risk of what we feel kind of we're able to do going forward.
And I wonder, Susan, do you want to talk about the things that aren't just medicines?
Yeah, I mean, I suppose for any one person, you don't know how effective the vaccines have been. You don't know how effective any treatment will be. And I think we have to take a multi-layered approach. Yes to vaccines as much as we can get them, but also just carrying on really thinking about what are risky places, thinking about ventilation, thinking about how many people are in spaces, thinking about how long you're in spaces, thinking about whether you are wearing a mask, whether other people are wearing masks. We all have to just carry on doing this risk assessment, risk management, protecting ourselves and protecting other people. And it's getting increasingly difficult with the sort of general culture that's been spread from the government across really so many different sections of the population who just stopped thinking about this. And I think one of the things we all have to do is really raise awareness of the number of people in this country who are still vulnerable to serious illness and death by us not taking these just very basic risk management strategies in addition to vaccination and any treatments people are eligible for.
Thank you. One more quick answer on this, Steve, because then we've got to go for some more questions.
Yeah, just very quickly to mention that, as well as vulnerable people, any infection has the potential, whether it's breakthrough, whether it's been treated, to cause long COVID symptoms. And the ONS survey showed us that we're over 2 million people suffering from long COVID symptoms very recently, many of whom, something crazy like nearly 20%, have had it for nearly 2 years. And I think going forwards, as everyone's saying, that this our society cannot bear that burden going forwards, and really ignoring prevalence, in my view, is a profound mistake for the long term.
And Danny.
Really briefly to add to all of the above, it's such a brilliant question that really goes to the heart of the matter that it deserves a whole week devoted to it. And lo and behold, we have that week next week, so join us for that. And just that we're in such uncharted territory, aren't we? That by all the kind of immune assays we can do, we're right at the bottom of the barrel. We can barely measure any detectable immunity in triple vaccinated people to BA.4/5. So what on earth are we to do, and where's it coming from? And the answer is that our kind of residual of immunity, the bits we can't measure, are kind of seeing us through most of the time, which is why hospitalizations aren't through the roof. But it's a really precarious point. So, it needs some serious thinking about where on earth we go next.
Thank you very much. And I'm going to go on to our next question now. Wendy, are you there? Can you join us?
I am, yes.
Far away.
Okay, you can't tell by looking at me how many antibodies I've got, whether I'm infected or whether I'm vulnerable. And to me, this is a huge issue. I went to have my rituximab infusion last Friday. I had to sit in outpatient clinic, and this week I had to have an ultrasound investigation. Only one of those places was I required to wear a mask, and that was the ultrasound, which of course for me was the least risky of all these things. So my question is, how can the guidance to the health and social services be refined so that services can better protect vulnerable people like me? Now there is apparently no mask mandate in those settings.
I'm wondering, Zubaida, would you like to talk a little on this one? And I know Zubaida feels really quite strongly about our need to protect everybody and the inequalities that the current system we have is producing. Anybody else want to talk about refining the guidance on masks?
I think politically we're going to struggle to redefine this, aren't we? Because I think a decision has been made, and I think the government has made it clear that we are delegating risk to the individual again, and the responsibility of risk to the individual. So I think what we're going to have to do over the next few months is really think about how we as individuals can stay safe and what we can do. So obviously there's social distancing measures that we can do, how we use our masks. I know it would be much better if everyone was wearing masks, but it's probably better if at least you do, at least an FFP2 mask. So it's about, in every situation, just thinking, is there an alternative scenario that I could do this social event that I want to do, or this necessary business piece of work, or this necessary hospital appointment with as low risk as possible?
I suppose I want to add that last Friday I was required to sit on an infusion ward having rituximab. It's not an oncology unit, it's not a haematology unit. So you can't tell by looking at us what's wrong with us. I'm asked to move once, but the second time after that I gave up. I was there for 8 hours in a cubicle. There was a limit to what I could do.
That sounds absolutely horrible, Wendy. I'm going to ask Zubaida, who's now decided she does want to tell me something. Come on.
Sorry. It's a really good point that was raised. And I think at the moment we are in an extraordinary situation where essentially we are living in a two-tiered society. We're living in a two-tier society in the sense that anyone who's remotely vulnerable, and I've been working quite a lot recently with disability groups, and there's a wide spectrum of disabilities out there, but anyone who's remotely vulnerable has to take their own measures, has to take measures into their own hands to protect themselves. But it just doesn't work that way, does it? It doesn't work that way where if you're wearing a mask but nobody else is, that you're fully protected. And I think we do have to go back to basics, and we do have to address these health inequality questions where we have to ask, well, is it right that a fifth of the population has to take measures into their own hands and essentially stay indoors while others exercise their right to not wear a mask? And so, Wendy, if you come along to our session in about 2 weeks' time, where we're going to be talking about 1 year on from Freedom Day, we're going to be talking a lot more about this, but I think you have absolutely every right to be angry that you've essentially been abandoned.
Thank you.
Steve.
Sorry, just very, very quickly. I mean, Alex is absolutely right. This is what is happening. The onus is being placed on individuals. Whether that's the right thing to do, I would strongly contest against, because in most areas of public health, we have safety nets. So for other infectious diseases, for driving with alcohol, for smoking, the government and public health bodies put in place a remit and make reasonable adjustments for people that are adversely affected by the worst extremes of these things. That isn't happening with this virus anymore. And I think we have to ask a serious question as to why that is, because it does seem to go against most principles of public health. And I do believe that it is an ideologically driven decision. I think many of us have talked about this before, and I'm sure we'll hear more about it in Zubaida's session as well. So yeah, I completely sympathize, Wendy. I think it's a disgrace. And particularly in a healthcare setting, it seems very short-sighted if you let half your staff become infected with this virus.
Susan.
Thanks. I was part of SAGE, Scientific Advisory Group in Emergencies Behavioural Science Group. And one of the last reports we were asked to provide was about how we should move from a society where we were governed by rules in terms of COVID to a more risk assessment, risk management kind of approach. That paper was published on July the 19th. It was actually held up for a couple of months in order to publish it. So Zubaida, maybe we should talk about it a bit on that day. But one of the main points it made was don't give all the responsibility to individuals. It's the responsibility of all sections of society, to government, to local government, to employers, to regulators, to planners, etc., etc. We went through all of those different sections of society, the kind of steps they should be taking. Sadly, it doesn't appear to have been listened to, but we will bring it back hopefully on July the 19th.
Thank you, Susan. And we're going to squeeze in one more question before we go, which comes from Kate Oakley. And she says, will Evishield become available, and will antivirals become available for those eligible from GPs, so that vulnerable people can go on holiday and away from their immediate postcode, or even abroad, and take them with them, as they currently do sometimes with prophylactic antibiotics? Anyone want to postulate a happy future like this?
Ellen, I think eventually we cannot continue to be centralized with all these treatments. So for all other infections, eventually this gets disseminated down to treating clinicians, doesn't it? Who make individual decisions for individual patients. And I think that something like that will eventually happen. And, you know, I often give patients prophylactic antibiotics, or I give them antibiotics to take with them on holiday as what we call rescue packs. I'm sure many of people will have heard that term. So it may be in the future that is possible, and I suspect it will be. But as Ravi makes a really important point, with antivirals, we've got this problem of resistance. And so we need to be really careful about the use of antiviral medicines. And things like sotrovimab and Evishield are injections. So usually those aren't given in primary care. But I do think access to treatment will get better in the future, but not for the foreseeable future.
I think we've probably run out of time now, and I would like to say a huge thank you to our guests, Alex and Ravi, who taught us so much. I've learned so much today, and to all our members, our regular members of Independent Sage. Thank you. Stay well. Keep wearing those masks for other people as well as for yourself, and we'll see you next week.
Thanks all. Bye.